Hello everyone, and welcome back to Money Power Health with me, Nason Maani. It's great to be back with you, and Charlie and I are very excited to bring you a new series of Money Power Health episodes starting today. As you know, in this podcast, we've been talking about the ways in which the wider physical and social environments we find ourselves in can profoundly shape our health, and how these environments in turn are shaped by inequality and by powerful commercial forces. In some ways, what we've been describing is how much of what shapes health actually occurs outside of healthcare, outside of clinics and away from doctors. In the process of doing that, I've been contacted by clinicians who know only too well how frustrating it can be to attempt to treat patients only to send them back into the conditions that made them sick in the first place, or to try to devote themselves to making their communities healthier when those wider conditions are worsening, particularly for the most vulnerable, and as a result, patient numbers and the complexity of their conditions is increasing seemingly exponentially. In spite of these challenges, healthcare can and should engage with these wider forces outside the clinic. And one example of an initiative that has sought to do so in inspirational and innovative ways is the Deep End GP network here in Scotland. The Deep End GP network pools the experience and ideas of GPs in the most deprived areas and seeks to increase advocacy, mitigate burnout, and provide practical grassroots interventions to improve patient care in the areas with the highest patient need. Today, I have the great privilege of speaking to Dr. David Blane, Senior Clinical Lecturer in General Practice and Primary Care at the University of Glasgow, and the Academic Coordinator of the Deep End GP Group in Scotland. David Blane, hello and welcome to Money Power Health.
Thank you. Thanks for having me.
Oh, it's a real pleasure. And as I've been digging into some of the reports that you and your team have done about this topic, about deep end GPs and about what's coming through, I've just become really fascinated by it. So thanks very much for joining us today. Before we get into the work of the Deep End GP network and related issues, I was just wondering if you could tell us a bit about how you decided to become a GP in the first place, and then how you went from there to getting involved in this work.
Yeah, sure. So I did my medical school in Dundee in the east coast of Scotland, but I had a BSc year. I intercalated, so I spent 1 year in London in 2002-3, and that was a really formative time, I think, because the degree course was new. It was at UCL, and they just introduced a BSc in international health at that point. And I grew up for a bit in Kenya, so I'd had an interest in global health anyway. And I saw this course, I thought this looks ideal, and took a punt, applied, got on, and there was just a fantastic group of fellow students. There was 15 of us in the course. It was run by John Yudkin, and it was a real eye opener. So we were learning about the social, political, commercial determinants of health, and I was, studying a bit of history, a bit of politics, economics, development theory. Real eye opener for me, and I guess that kind of. I suppose set me on the path which has followed, and then with regard to specifically GP, that came a bit later. That kind of came after I'd finished medical school, did my foundation years, and I was kind of toying with the idea of doing infectious diseases. I had ambitions through medical school of working for MSF, but which never transpired. And I think at that time, we were the first cohort of modernizing medical careers. I just felt the kind of flexibility of general practice, the kind of community-oriented nature of it, the continuity side of it, and also the breadth of the training were all attractive, and those were kind of the main decision points for me.
And so you become a GP, but then how do you go from there to this interesting split that you have between teaching, academic research, clinical practice, and hosting this network? How did that come to be?
Yeah, so I mean, first of all, I don't know if I'd go as far as to say I'm hosting the network. I'm part of it, and hopefully I kind of have a good role to play. But yeah, I think that again, a lot of sort of serendipity involved. I had just done a sort of standard GP training program in the east of Glasgow. So I was based at the Glasgow Royal, and my training practice was one of my group were mostly practices in areas of deprivation in the east of Glasgow,
Mm.
um, and I guess after that 3 years, I became aware of this fellowship post based within NHS Education for Scotland. These were called Health Inequality Fellowships, and again took a bit of a punt, applied for it, got on, and during that year, that was in 2010, the Deep End had just started. They'd had their first big national meeting,
Mm.
their kind of launch meeting, if you like, in 2009. So I became aware of that. I became much more aware and read much more about the research that Professor Graham Watt and Stuart Mercer were doing at the University of Glasgow at that time. You know, the kind of the legacy and the influence of Julian Tudor Hart. And then really during that year decided I wanted to do the academic fellowship and see where it took me.
Wow, fascinating. And I guess it's time to talk about the Deep NGP network, what it is, and how it works. I saw that there was a really fascinating quote in one of the reports, sort of 2013, 2014, that tried to summarize what the Deep End GP network was trying to do. And they said that they were attempting to break the inverse care law, which I thought was a really good way of thinking about it. So could you tell us a little bit more about what it is that the Deep End GP network does?
Yeah, sure. I mean, I think the inverse care law has always been there as the kind of context, and for any listeners who are not familiar with it, although I'm sure most are, this was an expression coined by Julian Tudor Hart, who's possibly the most influential GP in the history of the NHS. And he said that the availability of good medical care tends to vary inversely with the need for it in the population served. And he went on to talk about the really the malign influence of market forces and how they would further exacerbate that inverse care law. Part of the idea with the inverse care law is that there's a fundamental issue with how we distribute healthcare resource, and we don't really take into account where needs are greatest. It's this kind of flat distribution, and that's particularly evident in general practice, where we have GPs working in areas of high deprivation, where we know that needs are greatest, where we know that physical and mental health comorbidities are more concentrated, where death happens 10 to 15 years earlier, where healthy life expectancy is 20 years shorter, and yet we have GPs there who are fewer in number, who are less well funded, who have less time to spend with patients. And that really is the kind of the fundamental of the inverse care law. It manifests as a lack of time to do what could be done if resources were applied according to needs. There's another element of the inverse care law, which is about how people can navigate complex systems, and part of what we've tried to do with different deep end initiatives is help the most disadvantaged patients and folks to navigate those systems, make them easier to navigate.
So my exposure to the work of Deep NGPs has been through these reports that are produced periodically. From my reading of them, they reflect, I guess, evaluation, real world evaluation and sometimes qualitative evidence about navigating these challenging areas, about the challenges facing GPs in these areas, about the needs of the population, or perspectives from civil society who are involved in dealing with these. But I'm sure that a lot more goes into it in terms of what GPs put in and get out of the deep end GP network, and then the work that's involved behind those reports and other initiatives. Could you speak to some of the outputs involved and what their purpose is?
Yeah, so I mean, I guess going back maybe to the start, in 2009, Professor Watt, Graham Watt, and colleagues, I think they were tasked with producing a report on health inequalities, and they were very keen that it wasn't another desk-based rhetorical exercise, and that it actually attempted to engage with practitioners who were working in those most disadvantaged areas. So that was the starting point, and I think from 2009 on, we've had 3/4 of deep end practices, and again, just to put a bit of context on that, at the time there was just under 1,000 GP practices across the whole of Scotland. That number has dwindled over the last 2 decades. We're now sitting just over 900. But the deep end was an arbitrary cutoff of the 100 most deprived. So practices serving the highest percentage of their registered patients living in the 15% most deprived SIMD postcodes, as that's the Scottish Index of Multiple Deprivation. And we've had 3/4 of those 100 practices have engaged in meetings. A smaller number have been involved in a steering group, which has met. I can't even count how many times. It's dozens of times. Initially, it was in the evenings. Now we have in the afternoon, roughly every 6 to 8 weeks. But I guess that whole process of engagement led to a sense of solidarity, really, a sense of kind of common purpose, a sense of identity amongst deep end GPs, a sense that actually there's something here that we need to advocate for. We need, the status quo is unsustainable, and I think if nothing else, for those GPs that have been involved in the deep end project, if you like, I think there's been a bit of a sense of meaning and purpose and hope that has been derived from it. Of course, that can be a frustrated hope at times as well, because we've had some GPs who've been involved in the steering group for 5 years and then not seen much change on the ground, and then felt, actually, I need to take a step back. So it's not been all rosy.
No, and certainly the last couple of reports really put this in perspective. So there was a prison health report and there was a cost of living report. I encourage listeners to go and look at them, but really striking insights into the challenges in general practice in these areas and how linked they are to forces and factors outside of general practice, and I think that's one of the things that I find quite powerful about these reports is they are at times quite critical of things that could be done better within medical leadership, and strategy and resources, but they are also, they powerfully acknowledge the extent to which wider forces, either at the local level or national level, have to step up and are accountable. And I thought that was particularly notable in the prison health report. And I was just wondering if I might ask you a bit more about that, if you're okay talking about it.
Sure.
When you're putting something like that together as a group, how does one go about that? And when do you decide, okay, it's time to write this up? And what are your definitions of success with something like that? Because obviously that's a huge challenge. It involves loads of different people.
Mm.
You know what I mean? Like,
Of course.
when do you sit back and go, "Yep, that was a success. I'm glad we did that."
Yeah, I think that's a really good question, Nathan, and I think we could probably do better at evaluating our measures of success. I think, in terms of what topics are considered for these kind of roundtable discussions, I think that happens through the steering group, and it's often quite responsive to what the main issues are at that time, and that was certainly the case with the prison health report. It was that we had a number of members of, both on the steering group and from outside, who had been working in prison health, kind of drew attention to some of the challenges, and we felt this was a good topic. We hadn't previously covered it, and we felt that this was really a really important topic and timely, and then it's a decision of kind of who to invite to that discussion, and how we're going to affect change on the back of that. So again, that takes careful thought as to who to invite and how to pitch it, and hope that they can kind of buy into that, recognize that that there are issues, and that they might have a role in helping to influence them.
I mean, I have to say, I find them really compelling and kind of inspirational in a way, in that there's something very powerfully public health and sort of upstream about the vision, but combined with a sort of with perspectives that are really coming from the coalface, from the people who are most affected. And I just think that's something that is incredibly powerful. And I read a perspective from a member of the Deep End GP group that was part of an initial evaluation. And they said, I thought this micro-political level of the everyday stories we hear, people say that's just anecdote. It's not really evidence. But that's nonsense. This is evidence. What these people tell us is evidence of whether the system is working or not, whether society is functioning or not functioning. And I feel like what these reports are doing is almost reflecting that back. It's not just saying, I'm seeing this type of patient and I'm unable to help them in this way. Please help me help them better. Help with my medical firefighting. They're sort of saying, these are the lived experiences of people. They're happening for these reasons. Deal with the upstream as well as the immediate. Help me firefight, but help stop fires in the first place. And I think it's incredibly powerful. So really, congratulations. And one of the examples that really struck me was in the cost of living report actually included a draft letter that people could send about living in cold, damp houses and the effects this was having on their health. And it was almost like a draft letter that people could send to help notify the authorities and help build pressure to improve housing quality. I mean, how does this kind of thing come together? At what point do you balance the fact that these are so difficult and intractable issues with the fact that something has to be done? We have to find ways to help and to innovate.
Yeah, I mean, I think we recognize that we have different spheres of influence, and I think in relation to the kind of bigger question of what is the role of primary care in mitigating health inequalities, then we generally in anything I'm doing related to Deep End, and I know that's the same for my colleagues, we kind of very much recognize that the fundamental drivers of health inequalities are related to unequal distribution of income, power, and wealth, and factors which lie outside the NHS, but equally, as we've described and discussed with the inverse care law, the health service does have a role to play, and I think you're right in terms of that kind of bearing witness piece, in that we have a very privileged position within communities, in seeing and witnessing some of the stresses, some of the real grinding daily challenges that people are bearing and are experiencing, and we have the power and the voice to be able to articulate that in a way which often they don't, for various different reasons. And I think that's a responsibility as well. I would also say that I think there's scope for us to include the kind of the voice of lived experience more or differently. We're not really kind of there yet at the moment, but we're kind of trying to reflect it through that practitioner experience.
I mean, I think we could go on and on about this, because I really did love, as the more I dug into the reports, the more I thought, gosh, this is a goldmine here of reflections on structural issues and the acute impact of those within healthcare and without healthcare. Really fascinating. But I guess I wanted to also take some time to talk about the fact that working as a GP generally has gotten increasingly difficult over the last 5-10 years, and I assume that's particularly the case in these kind of deep end GP practices. And you must be speaking to people, just through your experience and speaking to these kind of networks of camaraderie that you speak to, they're sharing these difficult circumstances. What do you think has changed over this time in terms of the challenges that you face? And what do you think's changed over this time in terms of the challenges your patients seem to be facing?
Yeah, so I think there's a couple of things there. One is the broader context of a decade plus of austerity. I think that's the fundamental context, is that there are more people struggling on lower incomes, more people struggling with addictions and mental health distress as a result of that. There's cuts to services that were there as kind of plugging the gaps of the welfare state, and those cuts have been made. Have felt hardest, and have hit hardest those areas of greatest need in the most deprived areas. So it's been a kind of a double whammy in terms of not only the direct impact of austerity on individuals, but also the support networks. And then I think alongside that, we've had again a decade plus of underinvestment in primary and community care services, and there was a report in the Lancet a couple of years ago that we often refer to, which shows the change in consultant numbers over a 10-year period. I think it's 2008 to 2018, and in every country of the UK, the numbers have gone up steeply. Consultant numbers have increased steeply, and GP numbers have either flatlined or gone down. And what we know from decades of work, work by folks like Barbara Starfield, about the real fundamental importance of strong primary care in preventing and containing health issues within communities, and kind of, when that primary care system breaks down, then you see people having to bypass that and go direct to A&E services, or you see GPs who simply don't have the time or the capacity to maybe investigate things locally, and having to refer up to the hospital, and then the hospital becomes overwhelmed, and then more money gets pumped into the hospitals. So it's a kind of a bit of a vicious cycle there of underfunding, really, and kind of fragmentation of that first primary community care level of service.
Yeah, I mean, it's that the cycle you describe is, it's both, I think, become increasingly obvious, as you say, but also there's something that feels fundamentally broken about that kind of cycle. And particularly when you're dealing with situations where, as we talked about in another episode, health is really a means to an end for most people. Health is like just a prerequisite so that they can go and do the things they want to do with their lives, to make the choices they want to make. It's a means to any end, essentially. And you have this decade of stagnation where both the means are kind of taken away, but then also health as a means is taken away. And there's a kind of a relationship between the two that becomes quite difficult. And I guess I imagine that this leads to both the development of coping mechanisms, of resilience, of responding as a practitioner in these kind of settings. And I wonder if we could reflect on those for a little bit, because I'm sure that in part because of engaging with this work and speaking to these people who are often going through really challenging circumstances, and certainly my experience, my dad was a social worker in Northern Ireland, was that they were some of the most resilient people that I've ever met. What have you learned both as a as collective, in terms of the skills that make a good deep end GP, both in terms of just maintaining positivity and doing the best with what one has.
Yeah, it's a difficult question because I think we all probably all have different ways of coping. I mean, I think there's certain things which are reasonably universal in relation to kind of what keeps you going and what motivates you, and we found that to a certain extent in our evaluation of the Deep End Pioneer scheme, which was a kind of early career GP program to increase recruitment of GPs to deep end practices and retention of GPs within deep end practice. So pretty core to this discussion, recruitment and retention. I guess we use this notion of self-determination theory and kind of related concepts, and part of that is about connection. So feeling part of a team, I think, is important. So you're not feeling that it's all on you and that you're isolated. So practically that could be trying to build in time to your working day to meet with colleagues, have coffee, have lunch together. Often these things have been squeezed out over time. Like literally, GPs up and down the country will be having a sandwich at their desks while they're checking blood results or
Yeah.
kind of processing discharge letters or whatever. So I think that's really important. The things with self-determination are around competency, mastery. So you've got the skills to do the job. You feel there's a degree of autonomy and control over what you do. You've got that connection piece, and then the fourth element is around a sense of meaning and purpose in your work. Yeah, I mean, I think for me, working in kind of deep end practices, you really feel that you can make a difference sometimes, and you certainly feel like you're doing work that's important and meaningful.
And from the perspective of the I guess the sum total of all these different relationships that you've been able to enjoy, not just with patients, but I understand that part of this work also involves meeting with support workers, civil society, especially when it comes to the broader work around the Deep End GP network. Could you speak a little bit about how you feel your understanding and approach has changed, or what you feel you've learned from them about what's most important to health or about life more generally?
Yeah, it's not something I've thought so much about. I mean, I guess in terms of the public health perspective, I think there's something to say about the potential of general practice, and I guess this is how I view that sort of interface between uh, primary care and public health. And I'm minded at this point of a kind of expression that Graham Watt, who's the emeritus professor of general practice, used to say around public health. And he used to say that that there are public health interventions that involve no contact, zero contact with the public. So things like legislation, regulation type approaches. Then there's public health interventions that involve episodic or single contacts. So you might think of vaccination program or certain screening initiatives. And then there's public health interventions which involve relationships built on trust over time, continuity, and most of that happens in primary care. I think the other thing is that GP practices have a defined patient list, so we have a defined denominator. So in terms of understanding what has and hasn't happened, we have the potential to measure, not only what we do, but also what hasn't been done. And that was Julian Tudor Hart's example of anticipatory care where, he was able to literally measure the blood pressure of every single one of his patients by the measurement of omission, by keeping records and finding out what hadn't been done. And that fantastic example that he gave was, the last person in Glencorrig, where Tudor Hart practiced, who had his blood pressure measured, only agreed to, he didn't like doctors, as many people don't. He only agreed to have his blood pressure checked if he was the last person in Glencorrig to get it done. And his incredible story is his blood pressure was over 200 systolic. This was a kind of walking time bomb.
Wow.
And Tudor Hart worked with him over many years, controlled his blood pressure, and prevented the strokes, prevented the diabetes and whatnot. And I guess that's the potential of general practice is in what it can prevent. If you work with people and care about their future and not just about their kind of immediate presenting complaint, then you can really make scale that up. That's population health.
Yeah. No, absolutely. And I understand that, in some ways the deep NGP, approach, trying to bear witness to some of these more systemic issues of finding the best ways to do what you can for your patients collectively now and in the future. That this must have lessons for clinicians in other countries, in other challenging settings. What has been your experience of, I guess, cross learning between yourself or yourselves as a group and clinicians who are also dealing with areas of high levels of multiple deprivation, but maybe in other country contexts?
Yeah, so the deep end started in Scotland in 2009, but as you kind of allude to there, Nason has been spreading, and there's now over 15 different deep end networks across the UK and a few internationally as well. And I think they all have their different strengths and challenges, and some of them are kind of really blazing a trail. I'm thinking, for instance, of there's groups in the north of England who are really doing some great inclusive research and inclusion health research in deep end practices. That I think there's lots we can learn with that, and very much also as part of that, including really strong patient voice in that research process. I think which is for me is kind of fundamental. And then also, we've come to learn about other places like parts of Belgium, where they have some fantastic community health centres, where they've been thinking these things and doing this work for decades. I think in many ways there's nothing new under the sun, right? So there's been examples of really good community oriented primary care across the world for a long time. But yeah, we managed a kind of really interesting trip to Belgium a couple of years ago and saw some of what they've been doing. And again, what struck me the most was their sort of resources in these places and their ratios of doctors to GP to patients were much better, much healthier than what we're dealing with. If I don't know if all your listeners would know, but average sort of GP to patient ratio in the UK is probably around 1 GP per 2,000 patients, like full-time GP. But the ratios in these community health centres were kind of 1 to 650 patients.
Gosh.
So you can imagine what, and it's time, again, kind of comes down to time and the potential of what you can do with that time.
No, I'm absolutely. I'm struck just as you're saying this that we have very different senses of what's normal. I think part of the challenge in these issues achieving greater salience and even getting a common understanding of the challenges is that we have a different layers of us and them kind of lenses, I think, that apply here. There's the us and them lens, that applies between, so, the Scottish context or the UK context and other country contexts, where actually completely different levels of support are standard. But then there's also the kind of us and them context where, the experience of those in these most deprived areas is quite alien to the experience of those at the other end of the inverse care law, and those who often are, have the time to write letters to MPs, have the time to complain, about what matters to them, and there's this sense that there's like an inverse voice law as well.
Yeah.
in that sense, I suppose. Have you thought about how to break down that kind of those kind of barriers? Have you any reflections on the kind of harmfulness of these kind of us and them visions of the world? I mean, it if anything, maybe those are breaking down a little bit in the sense that, now at least there's news articles about a cost of living crisis, whereas of course you've probably been dealing with people who've been in a cost of living crisis for the last decade, and now there's a wider understanding of the challenges of waiting lists, where again, this is something that a subgroup of the population have been dealing with for a long time.
Yeah. No, I think that's a really good point. I think when the Deep End started in 2009, there was much more of a kind of sense of a canary in the coal mine in some ways, in the issues of recruitment and retention were more acute, in areas of deprivation. I think also remote and rural areas in Scotland have always had their challenges as well, but now, everywhere across the board is struggling with recruitment and retention. So it's a bit harder to make a kind of plead a special case for deep end practice, and I think we recognise that, and I guess our response to that would be Michael Marmot's notion of proportionate universalism, so of services which are universal, so there's kind of across population, across society buy-in, but that there's some proportionality to them. The challenge, of course, is how do you operationalize that? How do you measure the need and resource accordingly is difficult, but not impossible. And if we genuinely care as a society about health inequalities and all the negative consequences that they have for everyone, then I think at a certain point we need to kind of translate that rhetoric into resources on the ground.
Yeah, and I completely agree. I mean, it's a very simplistic, maybe a simplistic analogy, but I think wider scholarship around the social determinants or drivers of health, and what we know about how our health is shaped by forces beyond us. We're interdependent enough that we're sort of like cells in a body, really. It would be ridiculous a cell in one leg of a body and say, well, I'm healthy, I'm fine. Doesn't matter, there's a localized affection in the other leg, because we're doing great. You know what I mean? And then as that spreads into sepsis, you're like, well, it hasn't reached down to where I am in this particular toe, so it doesn't really matter too much to me. Whereas in reality, we are literally that interdependent, that there is really no us and them in that sense. And these inequalities they don't cause localized harm, they cause a generalized weakening. Maybe it has to get acute before that understanding really spreads more. I don't know.
Yeah, building on your analogy of the spreading infection, I mean, I think what we don't want is a kind of the amputation response, where you almost like social apartheid,
Yeah.
and with growing inequalities financially, socially, politically, over the last, I don't know, 30 years probably, a polarization of views, the lack of empathy, coming through sometimes in our discourse. I think if your readers haven't, or your listeners rather, haven't read Darren McGarvey's latest book. I would make a plug for that. It's called The Social Distance Between Us, and I think that he writes really clearly across all the big sectors. Like, he's got chapters on health and education and policing and prisons. He's one of the kind of the most prominent commentators in Scotland, certainly, around how we can narrow that social distance, and how we can kind of increase the empathy, which I think would benefit all of us.
No, absolutely. No, I'll put a link to the book in the show notes because I think that's so important. You know, in this context, empathy is a bit like a pain response. You can't remain healthy without a pain response because it's so fundamental to you knowing what needs fixing. And at the level of a society, if we can't compassion, empathy, in my view, they serve as important to function. You know what I mean? Like if you become numb and siloed away from these kind of harms, then that's hugely damaging. You know, it's a fundamentally unhealthy aspect of a society. So no, completely agree. Well, I'm just conscious that our time is nearly up, and this has been fascinating. I try to end each podcast with a question for early career folks, you know, either students or people who are just starting out, whatever field. And, you know, there's no doubt that a lot of what you've described are, you know, really challenging working environments, stacked odds, but obviously also some examples of real innovation, of like kind of almost like a guerrilla camaraderie among deep end GPs and coming together and trying to find ways around this. So with all that's going on and, you know, the news about the challenges facing GP practices more generally, and what you've described in terms of a message to early career folks, would you still recommend it to people? Would you recommend it to yourself if you could go back? And if so, why?
A resounding yes for me. I think general practice is still one of the best jobs in the world. I think it's not been particularly easy recently, but I think there's still so much there. Effective team working to help folks who you know who need it, and that's still really powerful motivator for me. I think also there's lots of, you know, flexibility in general practice to take on other interests. So really, what kind of whatever your interests within health are, there's a space to find it within a GP career.
Fantastic. And one last question: the number. I think there's a report in the BMJ. This a few years ago now that estimated the number of doctors in, I think it was England, from working class backgrounds, and it found that it was incredibly low. I think it was in the region of 4 to 6% or something like that. And you know, other reports have shown that if your parents are a doctor, you know, that increases your odds of becoming a doctor by, you know, over 10 times. It seems to me that a lot of what we've talked about are, you know, reflect the need for social change and for empathy. And when you think of social change, that doesn't really feel something that one group does to another group. That feels like something that kind of emerges from within. What are your thoughts on widening access to medicine and to general practice for people whose lives better reflect the needs of those kind of populations?
Yeah, I think it's really important. I think it's something that we've tried to support as a network in a couple of ways. So there's two initiatives in Glasgow that I'm familiar with related to widening access. The one is called the REACH program, which goes into schools. It tries to provide, you know, even something simple like work experience is much more challenging if you don't have anyone in your kind of family who can facilitate that. So that's one initiative, and they also try and, you know, provide a bit more support and coaching in terms of what to expect with the admissions processes and all that side of things. And the other one's called the Glasgow Access Program, or the GAP program, and that again is targeted at pupils from certain areas, disadvantaged areas, provides a kind of slightly reduced grade entries, but these are still fantastic students. And if they get through the gap year, then they get into medical school. So I think these are good good initiatives.
Oh, that's great to hear. Well, David, thank you so much for your time on the podcast. It's been a pleasure speaking to you, and I'll put plenty of information in the show notes about Deep NGPs, including the reports that we discussed. Thank you so much for your time.
No problem. Thank you.
Well, that's it for another episode of Money Power Health. Huge thanks to my guest, Dr. David Blane. It was wonderful to speak to him, and you really felt the passion and determination come through and what it means to be a GP in these kind of settings. I'll include plenty of information in the show notes if you want to find out more about him or the work of the wider Deep NGP network. It is fantastic to be back recording podcasts for you, and plenty more are in the pipeline. So stay tuned. Thanks for listening, and I'll leave Charlie to read us out.
If you enjoyed this podcast, please consider leaving a rating. It helps other people find it. The music in this podcast was by Nason Maani. You can find more information about his music in the show notes. This announcement was read by the very talented Charlie Maani.